Okay, let's unpack this lateral hip pain. It's incredibly common, right?
Yeah, absolutely.
Yeah. Impacts so many people, whether you're an athlete, somebody just trying to walk comfortably, or, dealing with it as you get older. And for the longest time, our understanding and maybe how we managed it seemed to be guided by some, well, really persistent beliefs, maybe even myths.
Absolutely.
Yeah.
Myths is probably the right word. But thankfully, the last decade or so has seen a substantial body of evidence emerge. It's fundamentally changed how we can and really should approach this condition.
Specifically, gluteal tendinopathy.
Exactly. Gluteal tendinopathy.
And that's exactly what we're diving into today. We're taking a deep dive into a fantastic masterclass paper published just this year, 2025, in Musculoskeletal Science and Practice.
All right.
It's by leading experts, Allison Grimaldi, Charlotte Ganderton, and Anthony Nasser. And they take a really sharp look at those prevalent myths around gluteal tendinopathy, trochanteric pain, and hold them up against the absolute latest evidence.
Yeah, think of this deep dive as like your shortcut to being truly well-informed. We're going to pull out the most important nuggets.
Okay.
Moving away from those older ideas, focusing purely on rest, anti-inflammatories, or quick fix injections.
Right, the passive stuff.
Yeah, exactly. Towards a much more active, empowering approach. It's about education, smart load management, progressive exercise, and really looking at your overall health picture, too.
It signals a crucial shift, really. It's about understanding the actual issue, like at the tendon level, and building resilience, rather than just trying to dampen symptoms with passive treatments.
That's it in a nutshell.
So, shall we start taking on some of these myths head on?
Let's do it. I'm ready.
All right. Myth number one, maybe the biggest one, what everyone used to talk about. Trochanteric pain is related to an inflammatory condition of the trochanteric bursa. We called it trochanteric bursitis for years, didn't we?
We did. We absolutely did. And it's probably the most deeply ingrained myth out there. But the evidence from detailed imaging studies like MRI and ultrasound, and even what surgeons see directly, when they're in there, it consistently points to the primary pathology, the main problem, being within the gluteus medius and gluteus minimus tendons.
So GM and G-min tendons?
Exactly. It's gluteal tendinopathy.
So the bursa swelling.
Yeah.
That isn't the main problem then, even if a scan shows some fluid there.
Not usually in isolation, no. Yes, bursal distension, that swelling in the bursa, it can be present, but it's only seen in maybe 20 to 30% of people with soft tissue pain around the greater trochanter. And even then, it's most often found alongside the tendon pathology.
Okay.
Isolated bursal change, where only the bursa is affected, is actually quite rare, showing up in only like 2 to 8% of cases in some studies. It's really low.
What about the idea of inflammation, though? I mean, don't anti-inflammatories sometimes help people feel a bit better?
Short term, maybe. For pain relief, possibly. But when researchers have looked at the tissue itself, histological studies looking under the microscope at bursa tissue from people with this pain.
What do they find?
They find primarily fibroadipose tissue, basically fat and connective tissue, not the typical cellular hallmarks of acute or chronic inflammation. And clinically, think about it, you rarely see those classic signs of inflammation like redness, warmth, or significant swelling when you examine someone.
Fascinating. So if it's not inflammation driving it, what's the mechanism behind, say, tendon thickening that you sometimes see on scans?
Yeah, good question. Tendon thickening in this context is viewed more as a cell-driven adaptation. It's not really an inflammatory response.
An adaptation?
Yeah, a response to inappropriate or excessive loading, particularly compression. Think about how the gluteal tendons wrap over that bony lump, the greater trochanter.
Right.
Compression is highest in positions where the hip moves inwards, hip adduction, like when your hip drops or moves across your body. It's often a combination of that compressive load and tensile or stretching loads.
And the bursa might thicken for similar reasons.
It's possible, yeah. Bursal thickening might follow a similar kind of mechanical adaptation process.
Wow. That fundamentally changes how someone should think about their pain, doesn't it? If you thought it was bursitis and just needed rest and anti-inflammatories.
Exactly. You're potentially missing the real target.
Yeah.
The core message from the paper here is crystal clear. Trochanteric pain is not typically due to inflammatory bursitis. The main issue is gluteal tendinopathy involving the GM-ed and or G-min tendons.
Right.
Which means the first approach to management should be evidence-based strategies. Focus on education, load management, exercise, addressing both local mechanical factors and, broader systemic health factors.
Okay, great. Let's tackle myth number 2 then. Gluteal tendinopathy only occurs in post-menopausal females. We certainly see it a lot in that group.
It is definitely most prevalent there. That's absolutely true. In the LEA trial, that was a big randomized control trial specifically looking at GT.
Yeah, I remember that one.
Right. 82% of the participants were postmenopausal women. However, 18% were male.
18%.
Yeah. And other research shows it affects almost 1 in 10 older males.
1 in 10 older men.
Uh,
Okay, so clearly not only women. What about the age range? Is it always older people?
No, you also see it in younger females. And interestingly, a noticeable group are active runners, particularly during the postpartum period.
Ah, postpartum. Why then, specifically?
Well, similar to menopause, that drop in estrogen levels, which can be pretty significant during breastfeeding, it seems to temporarily affect tendon health and how the tendon tolerates load. Makes it more susceptible.
Okay, that makes sense. And the paper mentioned other hip conditions that can occur alongside those too.
Yes, it frequently coexists with things like hip osteoarthritis, and it's actually quite common following total hip replacement surgery.
Early after a replacement.
Yeah, the incidence rates vary wildly depending on the study and the patients, but can be anywhere from under 2% to over 35% in some groups, like younger, more active patients post-op. And it's also more common in individuals with things like acetabular dysplasia, where the hip socket is a bit shallow, because the gluteal muscles have to work harder for stability, which puts increased load on the tendons. One study found 42% with dysplasia had abductor pain, and 27% had tendon pathology on ultrasound.
So the takeaway for you listening is even if you're a man or younger, or you've already got another hip problem like OA or you've had hip replacement, don't automatically assume lateral hip pain isn't gluteal tendinopathy.
Absolutely. It's definitely worth considering.
Right.
That's the key point from the paper here. While the highest prevalence is in postmenopausal women, you need to rule it in, or at least strongly consider it, in males, younger women, especially those postpartum runners, individuals with other hip conditions, and those who've had a total hip replacement.
Okay, myth number 3. Palpation of the greater trochanter is adequate for diagnosis. You feel that bony lump on the side of your hip, press on it, it's sore. Diagnosis confirmed, right? Yeah. Simple as that.
Well, that's a really common assumption. And palpation is a useful test, particularly if it's not tender.
Oh, okay. If it's not tender.
Yeah. It's actually highly sensitive, technically speaking, and has the best negative likelihood ratio mentioned in the paper. What that means, basically, is if the greater trochanter isn't tender to touch, it's a pretty good indicator that gluteal tendinopathy is unlikely. It helps you rule it out.
Okay, good for ruling out. But you can't just use it to rule in the diagnosis if it is tender.
Precisely. That's the problem. Many people who have absolutely no pain at all are still tender when you press on their greater trochanter.
Oh, really?
Yeah. So finding tenderness there in isolation, it just isn't enough to confidently say someone has gluteal tendinopathy that's causing their pain.
So how do you get better accuracy then? What else do you need?
You combine palpation with active loading tests that actually stress the tendon a bit.
Like what?
Well, the research highlighted shows a huge difference when you combine them. For example, if you have no tenderness on palpation and you can perform resisted hip abduction, that's pushing your leg out sideways against resistance without any pain, the likelihood of actually having gluteal tendon pathology show up on an MRI drops significantly, from like a baseline of 59% down to just 14%.
Wow. Okay, that's a big drop.
It really is. And conversely, if you do have tenderness on palpation, plus you get pain during either resisted hip abduction or holding a single leg stance for 30 seconds, the likelihood of seeing that gluteal tendon pathology on MRI jumps dramatically. From that same 59% baseline all the way up to 96% with resisted abduction pain and 99% with single leg stance pain.
99%.
Yeah.
Okay, that's pretty definitive. So it's the combination that's powerful. Don't just rely on poking the hip bone.
Exactly. That's the practical takeaway from the paper. Always pair palpation of the greater trochanter with these active loading tests, particularly resisted hip abduction or the 30-second single leg stance test. That combination significantly improves your diagnostic accuracy.
Got it. Okay, myth number 4. Diagnosis and management planning should be based primarily on imaging findings. You get an MRI or an ultrasound, the report tells you what's wrong, and that dictates the treatment.
Oh, yes. This is a really common trap, and it's understandable why people fall into it, but relying solely on imaging can be very, very misleading.
Why is that?
The key issue, as the paper highlights so well, is that changes in the gluteal tendons or the bursa. They're incredibly common in people who have absolutely no pain at all.
Really? No pain, but changes on the scan?
Exactly. The findings don't always correlate with symptoms.
How common are these findings in, like, asymptomatic people?
It's surprisingly high. One study using MRI found paratrochanteric abnormalities, so changes around the trochanter in 88% of asymptomatic hips.
88%.
Yeah, and specifically looking at tendinopathy, those degenerative changes on MRI have been reported in anywhere from 50% up to 88% of asymptomatic individuals over the age of 45.
So potentially half to nearly 9 out of 10 people over 45 without hip pain might have something show up on a scan related to this.
Precisely. Now, it's true that people with pain are more likely to have more significant levels of pathology, things like moderate tendinosis, maybe a partial or even a full tear. That's more common in the symptomatic group.
Okay.
But simply the presence of changes is a really poor predictor of whether someone is actually experiencing pain from those changes. If there's absolutely no pathology on imaging, well, that makes GT less likely.
Right.
But finding changes on a scan doesn't automatically confirm that those changes are the source of the patient's current pain. Something else could still be causing it.
This is so important for listeners who get imaging done. Seeing words like tendinosis or tear on a report can be really scary, but it doesn't mean that's definitely the problem or that it's even causing pain.
Exactly the point the authors make. Degenerative changes in the gluteal tendons, bursal thickening. They're extremely common findings in both symptomatic and asymptomatic adults. Imaging findings are an adjunct. They're part of the puzzle. They must be paired with a thorough clinical examination to understand if those findings are actually relevant to the pain you're experiencing.
So clinical picture first.
Clinical presentation first, imaging second, and really only when necessary to clarify things or rule out other issues.
Makes sense. Okay, myth number 5. Gluteal tendinopathy is a self-limiting condition. Just wait it out, take it easy, and it'll go away on its own eventually.
Oh, we wish it were that simple. While, sure, some people might improve over time, the evidence doesn't really support the idea that this reliably just resolves itself for everyone.
Sure.
There aren't actually many high-quality studies specifically looking at the natural history of GT, what happens if you just leave it alone. But one study did follow patients for 11 years.
11 years. Wow.
Yeah, and of those they could track down, 45% still had symptoms after over a decade.
Almost half still symptomatic after 11 years. That's not self-limiting by any definition I know.
Not for a large proportion, no. We also got some really interesting insight from the Wait and See group in that LA trial we keep mentioning.
Right, the control group.
Yeah, they received minimal intervention, basically just one brief advice session, and that was it. The results were quite telling. 71% hadn't recovered in the short term at 8 weeks.
71% still having problems.
And nearly half, 48%, still hadn't recovered even after a full year.
Wow. That really puts the just wait it out approach into perspective, doesn't it?
It certainly does.
Yeah.
And maybe even more concerning, that same 11-year follow-up study found that 35% of the original GT patients had gone on to develop hip osteoarthritis in that hip.
35%. Compared to
0% in their control group who didn't have GT initially, which, hints at a potential longer-term link or maybe a consequence if the condition isn't addressed effectively.
So for anyone dealing with this, just assuming it's going to magically disappear probably isn't the most effective strategy. And getting some early evidence-based help might actually prevent it becoming a really long-term problem, maybe even reduce risk elsewhere.
That appears to be the case. The paper's point is, while perhaps around half the people might slowly improve over 12 months with very minimal input, just as many people experience persistent or recurrent symptoms. Early, appropriate intervention may significantly reduce the risk of it becoming chronic and potentially mitigate its impact on adjacent joints like the hip joint itself over time.
Okay, myth number 6. Gluteal tendinopathy is due to a tight ITB, and treatment should include ITB stretches. The IT band, another one that's been around forever.
Oh yes, the iliotibial band. The historical thinking was that a short or tight ITB caused friction or excessive pressure over the greater trochanter, and that led to the pain.
Right, the friction syndrome idea.
Exactly. And this led to treatments focused on stretching the ITB, or foam rolling it relentlessly, or even, in extreme cases, surgery to physically lengthen it.
And the evidence for this, does it hold up?
It simply doesn't support that idea. There's really no good evidence to show that people with gluteal tendinopathy actually have shorter ITBs, or reduced range of motion on tests like the Ober's test, or even shorter hip abductor muscles compared to people without the condition.
Okay, so the premise is flawed. And what about stretching the ITB as a treatment, particularly those stretches pulling the leg across the body?
especially stretching that takes the hip into adduction, so moving the leg inwards across the midline.
Mm.
It's just not supported by evidence for insertional tendinopathies like GT. In fact, it can often be provocative.
Provocative. It can make it worse.
Yeah, potentially. Because those positions, pulling the hip into adduction, they compress the gluteal tendons against the greater trochanter. You're adding load, specifically compressive load, that often irritates the already sensitive tendon.
So doing that classic ITB stretch might actually be counterproductive.
It very well could be, yeah.
So if it's not just ITB tightness causing the problem, what are the actual mechanical factors the research is highlighting now?
Well, the current understanding focuses less on static tissue length, like how long the ITB is, and much more on dynamic factors.
Dynamic factors, like movement.
Exactly. Things like an individual's morphology, their shape, specific joint positions they tend to adopt during movement, muscle structure and capacity, so things like weakness or even fatty changes that can infiltrate the gluteal muscles, and particularly movement patterns, what we call kinematic factors.
Kinematic factors. Give me an example.
Things like excessive hip adduction, the hip dropping inwards too much during walking or running, or the pelvis dropping down on the opposite side, or maybe the trunk leaning too far over. These patterns during weight-bearing activities like walking or climbing stairs can significantly increase the load, both compression and tension, on those gluteal tendons.
Ah, cool. That makes so much more sense than just trying to yank on the ITB. The focus needs to be on how you're actually using the muscles and controlling the movement, not just the length of the tissue.
Precisely. The practical application here is clear. Avoid painful stretches that put the hip into adduction and focus on lengthening the ITB. It's likely unhelpful and potentially provocative. Treatment needs to be tailored to your individual presentation, based on a comprehensive assessment, looking at your movement patterns, your muscle function, and addressing your tendon's load tolerance.
Got it. Okay, myth number 7. Corticosteroid injection is the best first-line management for GT. The quick fix jab.
Yeah, the CSI. It's a very common go-to, isn't it? And largely because CSIs are potent short-term pain relievers, they can work quite dramatically sometimes.
Right. And the old thinking was inflammation, so inject an anti-inflammatory.
Exactly. The rationale was often tied to calming down that perceived inflammation in the bursa, the bursitis. But as we've already established, inflammation isn't typically the primary driver here.
So what is the evidence on their effectiveness, especially looking beyond the first few weeks, long-term?
Well, while they can provide that quick, often significant pain relief in the short term, the long-term benefits typically aren't any better than just doing nothing, the wait-and-see approach, or certainly other active treatments.
Okay.
That LEA trial was really key here again. It directly compared education and exercise, CSI, and wait-and-see. And the education and exercise group came out clearly superior for overall improvement, both in the short term and the long term at 1 year.
And the CSI group compared to doing nothing.
Crucially, the CSI group was no better than the wait-and-see group when they looked at the 1-year outcomes.
Wow. So you might feel great for a few weeks or maybe months after the injection, but it doesn't seem to change the overall course of the condition for many people down the track.
That seems to be the case, and there are potential downsides to consider, too. There are ongoing concerns about CSIs potentially having adverse effects on the tendon tissue itself over time, things like reducing cell viability or impacting collagen production.
Okay, potential tissue harm. What else?
And behaviorally, they can sometimes hinder someone's ability to learn effective self-management strategies. They can promote a bit of a quick fix mindset, maybe reduce adherence to exercise programs because the pain is temporarily gone.
Right. Why do the exercises if the injection fixed it?
Exactly, which can then lead to people seeking repeated injections when the pain inevitably returns, rather than addressing the underlying load tolerance and movement issues.
So considering those potential negative effects on tissue and behavior, and the evidence showing education and exercise is actually better long-term, it sounds like CSI should probably be, well, not the first thing you reach for.
That's certainly the conclusion the authors draw, and it reflects a growing consensus in tendinopathy management generally. Despite some early pain relief effects, given the potential negative impact on tendon health and patient behavior, and importantly, the availability of alternatives like education and exercise that have been shown to be superior in research. Using CSI as a first-line intervention may be best avoided for most people with GT.
Okay, myth number 8. The clam exercise is the best exercise to address abductor deficits in those with GT. Oh boy. I feel like I've prescribed this exercise and seen it prescribed a million times.
You are definitely not alone. It is incredibly widely used, almost synonymous with glute med strengthening for many people.
Right, the side-lying knee opening thing.
That's the one. However, when you actually look at the research specifically focusing on gluteal tendinopathy, there's a noticeable lack of evidence supporting its prescription. In fact, the clam exercise was explicitly omitted from the successful exercise programs used in those key RCTs, like the LE trial that targeted GT.
Omitted. They deliberately left it out. Why might it not be suitable?
Well, think about the position again. Side-lying, often with the hips slightly flexed, rotating that top knee open. That position involves the hips starting in or moving through adduction, and often some internal rotation.
Which we said compresses the tendons.
Exactly. It can impart those compressive and also frictional loads across the greater trochanter, which, for someone with an already irritable gluteal tendinopathy, is often painful and provocative. It can stir things up.
Okay, so potentially painful.
Huh.
But is it even effective at actually strengthening the muscles we need to target, like the gluteus medius and minimus?
Not optimally for this purpose, it seems. Research that measures muscle activity using EMG shows that clams typically elicit relatively low levels of activation in the gluteus minimus and the anterior and middle parts of the gluteus medius.
How low?
Generally quite low percentages of maximum voluntary contraction, maybe in the 2–27% range, depending on the study and how it's done. This level of activation is pretty unlikely to provide the necessary stimulus for the kind of muscle adaptation strength gains, hypertrophy that's often needed to address the weakness, or sometimes even atrophy or fatty infiltration seen in these muscles in people with chronic GT.
Okay, so potentially low muscle activation and potentially provocative due to compression. What kind of exercises should people be focusing on instead then to effectively load those muscles?
Exercises that load the gluteus medius and minimus in more functional weight-bearing positions. That's where peak forces are naturally higher and more relevant to daily activities.
Like what kind of exercises?
Think exercises like single leg bias squats or deadlifts, step-ups, lunges, hip hinge movements, particularly when you start adding external resistance like weights or bands. These types of exercises align much better with the functional demands placed on the glutes during activities like walking, climbing stairs, or running. They provide a much better stimulus for strengthening and also for improving motor control in those functional patterns.
That's a significant shift in thinking for many clinicians and patients, I imagine. The exercise they've maybe always been told to do might not only be ineffective for strengthening, but could actually be making things worse by irritating the tendon. And functional weight-bearing exercises are likely the key.
That's the core message here from the evidence review. The clam exercise is likely inadequate to stimulate positive adaptation of the GM and GMIN muscles for this condition. Furthermore, the compressive and frictional loads it places on the tendons and bursa over the greater trochanter can be provocative. The focus should be on exercises that load the target muscles appropriately in functional positions, and crucially managing the load so they can be performed with minimal or acceptable pain levels.
Okay. And finally, myth number 9, all gluteal tendon tears need to be surgically repaired. Getting that word tear on an imaging report, that can be incredibly anxiety-provoking for people.
It absolutely is for both patients and the clinicians managing them. And it often leads to immediate concern and, referral for a surgical opinion.
But is surgery always needed when a tear is found?
No, not at all. It's really important to see this within the broader context of tendon degeneration. Tendinosis, that degenerative change, exists along a spectrum or continuum, and that continuum can progress to involve partial thickness tears and sometimes even full thickness tears. It's often part of the same underlying process.
So finding a tear on a scan doesn't automatically mean you need an operation?
Definitely not, especially partial thickness tears. They're actually very common, particularly in people over 50, and often they have a low risk of progressing clinically in a significant way, meaning they don't necessarily get worse or cause major problems. This strongly supports trying non-surgical management first, and often that's all that's needed.
What about full-thickness tears? Surely they need fixing.
Even full-thickness tears can sometimes be relatively small areas of deficiency within the tendon, rather than a massive complete rupture or detachment from the bone. Surgery becomes more likely to be considered in cases of substantial tendon detachment.
Okay, substantial detachment. What does that look like clinically?
These are usually individuals who have significant and persistent functional deficits that aren't improving with rehab, like a very noticeable Trendelenburg gait, that hip drop limp that just doesn't get better after a good go, say at least 3 months, of dedicated rehabilitation focusing on gluteal strengthening and movement control. Or they might have significant measurable abductor muscle weakness, like graded less than 4 out of 5 strength. Certain clinical signs, like a positive hip lag sign, can also suggest a more substantial tear might be present and potentially benefit from surgical consideration.
And the ALAVE trial, did they have participants with tears in their study groups?
Yes, they absolutely did. The participants included people with both partial and full thickness tears identified on their initial MRIs.
And how did they do with a non-surgical treatment?
Importantly, the outcomes of the non-surgical treatment, that education and exercise program in the LAPE trial, were not negatively affected by the severity of the tear. People with tears, even full thickness ones, still had successful outcomes with the non-surgical management.
That's really reassuring for anyone listening who's had an imaging report showing a tear. It doesn't necessarily mean you're headed for the operating room. Non-surgical options can still be very effective.
Precisely. That's the key point from the paper. Most gluteal tendon tears don't require surgery. Surgery is more likely warranted for those cases with substantial detachment resulting in persistent functional problems like a non-responsive Trendelenburg gait, significant abductor weakness, and ongoing pain and disability after a substantial trial, at least 3 months, of dedicated, appropriate rehabilitation has failed to achieve satisfactory improvement.
Okay, so we've busted quite a few myths there. Moving beyond those, let's talk about putting all this evidence into practice. How should we actually diagnose gluteal tendinopathy effectively? And then what does evidence-based management really look like day to day?
Right. So first, diagnosis requires careful consideration. It's not always GT causing lateral hip pain. You absolutely need to think about other potential sources, the differential diagnoses.
Like what? What are the main contenders?
The big ones are usually hip osteoarthritis, OA, or pain that's actually being referred from the lumbar spine, the lower back.
How do the symptoms typically differ between those and GT?
Well, gluteal tendinopathy pain, as we said, is usually quite focal, right over that greater trochanter bone on the side of the hip. It often radiates a bit down the lateral thigh, but usually not past the knee.
Okay.
And it's aggravated predictably by things that load or compress the tendon. Side lying on that affected side is often a big one. Single leg standing, walking, especially uphill or stairs, running, prolonged sitting, and especially getting up from a chair after sitting. You generally don't see significant morning stiffness, and distal symptoms like numbness or tingling down into the leg or foot aren't typical of GT itself.
Okay, and hip OA, how's that different?
Hip OA pain is often felt deeper, maybe more in the groin or the front or side of the hip. Sometimes people describe it as a C shape gripping around the hip, and it often does include stiffness, especially first thing in the morning or after sitting for a while. Difficulty with things like putting on socks and shoes is also pretty characteristic of OA due to loss of rotation.
And lumbar referred pain.
That can be tricky. It might present as a deep diffuse ache around the buttock, the back, or the lateral hip area. If it's true radicular pain from a nerve root, it's often more superficial, maybe burning or shooting, following a specific nerve pathway or dermatome down the leg. And it might be provoked more by movements or positions of the lumbar spine itself.
Okay, so paying really close attention to the specific type, location, and aggravating factors of the pain is absolutely key for diagnosis. What about the physical examination?
Well, as we highlighted when we were busting myth number 3, that combination is powerful. Palpation of the greater trochanter plus those active loading tests like resisted hip abduction or the 30-second single leg stance test. That significantly improves diagnostic accuracy for GT.
Right.
You'd also want to screen for hip OA using specific tests like the Faber test, flexion, abduction, external rotation, and definitely assess the lumbar spine, look at its range of motion, palpate the structures, maybe do some specific tests to see if you can reproduce their pain from the back.
And if it's still unclear after all that?
If there's still diagnostic uncertainty, sometimes a trial of treatment focused specifically on the lumbar spine for a short period can help clarify whether the back is the primary source or not.
Okay. And imaging, when does that fit into the diagnostic puzzle?
It really is an adjunct, not the starting point. The paper suggests using imaging primarily if someone isn't responding to appropriate conservative treatment as you'd expect them to, or if the diagnosis remains genuinely unclear despite a thorough clinical assessment. Or, of course, if there are any concerning red flag symptoms that might suggest something more serious is going on, like a bone stress injury, infection, or tumor, which are rare causes of lateral hip pain, but absolutely need to be ruled out if suspected.
Right. Okay, so let's say you've done your assessment. You're confident the diagnosis is gluteal tendinopathy. What does the evidence tell us is the most effective way to manage it? What's the first-line approach?
The evidence, particularly from that large LEAP trial, strongly supports physiotherapist-led education and exercise as the most effective first-line intervention. Remember, it was shown to be superior to both corticosteroid injection and just the wait-and-see approach.
Education and exercise. What are the core components of that approach? What does it actually involve?
Well, a huge component, maybe the most important one, is education, helping the individual truly understand their condition. What tendinopathy is, what it isn't like, it's not primarily inflammation, how tendons respond or sometimes maladapt to load.
Empowering them with knowledge.
Exactly. This empowers them to actively participate in their recovery and self-manage effectively. And then, building on that understanding, load management becomes critical.
Tell me more about load management. What does that look like practically?
It's really about controlling exposure to those provocative, sustained positions or activities that put high compressive or tensile loads on the tendon.
Like avoiding side lying.
Avoiding prolonged side lying directly on the affected hip is a big one, yes. Using a pillow between the knees if you have to lie on the good side can help too. Also, avoiding sitting with knees crossed or standing with all your weight hanging on one hip, pushing it out to the side. Basically, avoiding positions that force the hip into deep adduction where that compression on the trochanter is highest.
Makes sense. What about activity levels?
It's also about managing the overall volume and intensity of activity, not doing too much too soon, especially after a period of rest. The paper mentions that general rule of thumb for tendon loading: try to limit increases in things like walking distance, running time, or workout intensity to around 10% per week. Gradual progression is key.
And monitoring response.
Absolutely crucial. Learning to monitor your pain response over the next 24 hours after any activity or exercise. If your pain is significantly worse that night or the next morning, it's usually a sign you've overloaded the tendon and you need to back off slightly next time. Find that sweet spot of loading that challenges the tendon enough to adapt but doesn't flare it up.
What about specific activities like running or jumping? Things with impact.
Activities that involve rapid stretch shortening cycles, like running or plyometrics, can be particularly provocative for tendinopathy because they place high tensile and compressive loads on the tendon very quickly. Depending on how irritable the tendon is, these might need to be paused completely for a while, or significantly limited in volume or intensity initially before being gradually reintroduced.
You mentioned movement training earlier as well when we talked about mechanics.
Yes. Many people with GT demonstrate altered movement patterns, particularly control in the frontal plane, that side-to-side dimension. They might show excessive hip adduction, the hip dropping inwards, or the pelvis dropping down on the opposite side, or maybe the trunk leaning too far sideways when they walk, go upstairs, or do single-leg tasks.
And training can help that.
Yeah, movement retraining aims to address these patterns. Improving hip and pelvic control helps to reduce those excessive or poorly controlled loads on the abductor tendons during those everyday functional activities. It makes movement more efficient and less stressful on the tendon.
Okay. What about the exercise program itself? What kinds of exercises are typically included?
It usually starts with exercises that are well tolerated, even when the tendon is quite sensitive. Often this involves isometric abductor loading.
Isometrics, holding a contraction without movement.
Exactly, like pushing your leg outwards against a wall or belt and holding it. These are often well tolerated, and there's some evidence they might even have a temporary pain-relieving effect, an analgesic effect.
Okay, starting gentle, then what?
Then you gradually progress to exercises that load the glutes more dynamically through range, usually focusing initially on controlling movement in that frontal plane. Things like side lying or standing hip abduction variations, bridging progressions perhaps with band resistance around the knees.
Building at the challenge.
Yeah, and eventually incorporating more complex functional weight-bearing exercises. Exercises that load the whole lower body kinetic chain, but always emphasizing good hip and pelvic control throughout the movement. Squats, lunges, step-ups, deadlifts, like we mentioned earlier.
How do you know when it's time to make the exercises harder? What guides progression?
Good question. You typically progress an exercise when you can perform it with good technique, with minimal or no pain during the exercise itself or in the 24 hours afterwards. And when the exercise starts to feel relatively easy, say, the perceived exertion is moderate or less. The speed and the specific type of progression depend entirely on the individual's goals and their capacity. Are they aiming to return to high-level sport or just walk the dog comfortably? The end stage of rehab will look very different depending on those goals, progressing towards higher loads or more dynamic activities as needed.
Any simple pain relief strategies people can use, especially early on when things are quite sore?
Yeah, Definitely. If there's a significant limp due to pain, temporarily using a single walking stick or maybe even a crutch in the opposite hand can help to offload the painful hip and improve the gait pattern.
Okay.
And the paper also notes that using oral pain medication, like simple analgesics or NSAIDs, judiciously for short periods may actually be preferable to jumping straight to corticosteroid injections in the early stages, especially given the potential downsides of injections that we discussed.
Right. Managing pain without hindering the overall rehab process. Makes sense. What about those cases that just don't seem to get better, the really stubborn, recalcitrant ones? What do you look at then?
Yeah, those can be frustrating for everyone involved. This is where you really need to dig deeper and troubleshoot systematically. First, you have to thoroughly review the rehabilitation program itself.
What are you looking for?
Things like, how long has the person actually been doing the program consistently? Adherence is key. Were the exercises appropriate for their stage of recovery? Were they progressed correctly or maybe too quickly or not enough? Was exercise technique, especially managing that frontal plane control during weight-bearing tasks, adequately addressed and corrected? Sometimes people just haven't had the right guidance or haven't stuck with it long enough.
Okay, so reviewing the exercise part, what else? Are there non-physical factors that play a big role in persistent pain?
Oh, absolutely. Psychological factors are hugely important in almost all persistent pain conditions, and GT is no exception. They're often overlooked.
Like what kind of factors?
Research specifically in GT shows that higher levels of things like pain catastrophization, expecting the worst, magnifying the threat of pain, depression, anxiety, and lower levels of pain self-efficacy, that's your confidence in your ability to manage your pain, are all strongly linked to greater symptom severity and poorer outcomes.
So addressing the mindset is crucial.
It really is. While some people might benefit from referral to a pain psychologist, physiotherapists can and should address many of these factors. Simple things like educating people properly about their imaging findings, reassuring them that degenerative changes are common and don't necessarily equal damage is key. Addressing fear avoidance behaviors, helping people understand that some pain during rehab activity isn't necessarily harmful or causing more damage.
Reframing the pain experience.
Exactly. Empowering them with strategies to monitor their own response, use pacing techniques during daily tasks, and importantly, managing expectations by setting realistic timeframes for recovery. Tendinopathy rehab takes time, often months, and if people expect a quick fix, they can get frustrated and give up or start seeking out less evidence-based, often expensive interventions.
You also mentioned hormonal or metabolic factors earlier when we talked about who gets GT. Do they come into play for recalcitrant cases?
Yes, potentially, especially in persistent cases in post-menopausal women, where that decline in estrogen can influence tendon health and healing capacity. While the evidence isn't completely definitive on estrogen supplementation for GT specifically, it's something that might be considered in consultation with an endocrinologist in stubborn cases.
Any specific research on that?
There was one recent RCT mentioned in the paper that suggested a combination of hormone therapy cream plus exercise was helpful specifically for postmenopausal women with a lower BMI who had GT. So it's an emerging area.
Interesting. What about metabolic factors?
Things like high BMI, diabetes, high cholesterol metabolic syndrome components are increasingly recognized as potentially contributing to tendinopathy risk and maybe poorer healing. So in recalcitrant cases, considering consultation with a dietitian or GP to address these broader metabolic health factors could be relevant as part of a holistic approach.
Okay. What about other common treatments people often turn to when rehab isn't working? Things like shockwave therapy, SWT, or platelet-rich plasma, PRP injections.
Yeah, SWT and PRP are definitely considered frequently in those situations where standard rehab hasn't yielded the desired results.
What does the evidence say about them for GT?
Well, the current evidence base, as noted in this 2025 paper, still doesn't provide high-level support for using them as first-line treatments. There's some lower-level evidence and promising studies, but not enough robust data yet to recommend them routinely up front.
So maybe consider them later.
The general recommendation currently is to reserve them for cases where those high-value, non-invasive treatments, primarily education and exercise, have been diligently applied but haven't helped the individual reach their functional goals. More high-quality research is definitely needed to figure out exactly who benefits most from SWT or PRP and when is the optimal time to use them in GT.
And surgery as the absolute last resort.
Yes, surgical intervention for chronic GT or symptomatic gluteal tendon tears really remains a last resort option. While some case series looking at surgical outcomes show promise, the overall evidence level is still considered low compared to non-surgical options. There aren't many high-quality comparative trials.
Okay.
General recommendations for tendinopathy surgery in other parts of the body, like the Achilles or patellar tendon, usually suggest trying a comprehensive, well-structured, exercise-based management approach for at least 6 to 12 months first, before even considering surgery.
And that likely applies here, too.
Until better comparative studies exist specifically for GT surgery versus non-operative care, applying a similar principle, ensuring a thorough trial of quality rehab first makes good clinical sense.
Right. Finally, let's touch on measuring progress. You mentioned earlier it's a bit of a challenge in this area. How do we track if someone is actually getting better?
It is a challenge. Surprisingly, the paper highlighted this well. There was a recent international consensus project called ICON that specifically tried to develop a standard core set of outcome measures that should be used in all future GT research trials so we can compare studies better.
And what did they find?
Well, their conclusion was actually that currently no single existing measurement tool specifically designed for GT has demonstrated sufficiently strong measurement properties, things like reliability, validity, responsiveness, to change to be the definitive gold standard recommendation.
That is surprising for such a common and impactful condition.
It is. So while research continues to develop and validate better tools, the ICON group offered some interim recommendations for what outcome measures clinical trials should try to include as a minimum.
What are those?
They recommend asking the patient for their overall rating of change, like a global impression of how much better or worse they feel. Measuring pain levels using a numerical rating scale, NRS, particularly pain during specific aggravating activities like single-leg stance or climbing stairs, and also assessing relevant psychological factors like pain self-efficacy using a validated questionnaire.
Okay, those seem like core patient-reported outcomes.
Yeah.
Anything else clinicians might add?
Yeah, clinicians involved in the consensus also suggested adding measures for how pain interferes with sleep, tracking the worst pain level experienced, and using a more comprehensive measure of overall disability or function, potentially using tools like the VIAS check questionnaire, which is specific to gluteal tendinopathy, though still needs more validation, or a general quality of life measure like the EQ5D5L.
Okay, so still evolving, but some clear pointers on what's important to track. So bringing this all together, gluteal tendinopathy. It's incredibly common, it can be really impactful on people's lives, and yes, often quite persistent, affecting their pain, their function, activity levels, work, quality of life.
Exactly. It's a significant condition. But the truly exciting part, and what this paper synthesizes so well, is that thanks to really over a decade now of dedicated research, we have a solid body of evidence that systematically refutes many of those long-held traditional myths about its cause and, more importantly, how best to manage it.
Yeah. The key takeaway from this deep dive, pulling directly from this excellent paper, really feels like the absolute necessity of moving away from those older beliefs. Stop thinking it's just inflammation in the bursa, or that it only affects one type of person, or that a quick single test, or a scan finding, or an injection is the silver bullet answer.
It's really about embracing the evidence we now have, understanding the actual tendon pathology involved, recognizing the diverse group of people who can get it, men, women, young, old, active, less active, using a combination of clinical tests for a more accurate diagnosis, interpreting those imaging findings cautiously, always alongside the clinical picture, realizing it's not guaranteed to just go away on its own for many people.
And avoiding things that don't help or might harm.
Right. Wisely avoiding potentially unhelpful or even harmful treatments like painful ITB stretches or relying on first-line corticosteroid injections, and instead selecting exercises that actually effectively and progressively load the target gluteal muscles in functional ways, applying a comprehensive, patient-centered approach that's built firmly on a foundation of education, smart load management, and progressive, tailored exercise.
It really does feel like it's time to let go of the myths and properly lean into what the evidence is clearly showing us now for much better outcomes for people suffering with this.
Couldn't agree more.
So a final thought for everyone listening. Given how incredibly common gluteal tendinopathy is, and how persistent and, frankly, miserable it can be for so many people, understanding now that truly addressing it isn't about chasing some phantom inflammation or trying to correct an imagined IT band length, but it's actually about understanding tendon load, how you move, your muscle capacity, and all those individual factors we discussed. Does that fundamentally change how you might think about that niggly pain around your own hip, or perhaps how you'd suggest someone else approach theirs? Something to consider.